everyone gets settled. Thank you. So again, I'm Larry Boris, Executive Director of National Association of Worksite Health Centers, and I'm pleased to welcome you to our webinar today on key contracting issues for new and mature worksite health centers. We wanted to really focus on this issue. We covered so many COVID-related topics in the last year. We felt we wanted to get back on track, help people understand some of the key elements in designing and purchasing, managing, and operating and evaluating health centers. And so this is the first of several topics that we'll have relating to operations. Today, I'm pleased to have Stephanie Eckerly at Craig DeVault and Mike LaPena from the LaPena Group who'll be leading this discussion. We're going to be having a 90-minute webinar today, so get comfortable. And we're going to be covering a lot of issues. What I'd like to suggest you do is if you have a question during the sessions, go to the chat box and send me your question, and we'll try to relate to it either at that point in the session, but at the end of the program, we will be going around the table asking everybody for any questions or observations or comments that they would like to make. So there'll be an opportunity for everyone to have some input and get the information that you're seeking. If you find that we're not covering something you want to have covered or you have a question about, again, just raise your hand or participate in the discussion at the end, and we'll make sure our experts, Stephanie and Michael, will take care of it for you. So at this time, I'd like to turn the control over to Stephanie, and enjoy your day. Stephanie?
Great, thank you everyone. So I'm very excited to be here and presenting with Mike LaPena today. And just here's a little bit more about the National Association of Worksite Health Centers. If you are not familiar with the group, it's an amazing organization for both employers and vendors. And I also wanted to highlight before we get started that we've got several upcoming programs. We have an in-person program, Creating and Expanding Worksite Health Centers, September 9th through the 10th. At the Mid-America Club in Chicago, and that should be the 9th through the 10th. And then we have two different webinars where we will be diving deeper into some of the issues we'll be talking about today. So on July 27th, we'll be talking about different payment structures for worksite health centers. So payment issues, billing issues, reimbursement, and kind of the integration of how all that works. And then on October 18th, we're going to have a webinar about employee health records and really dive into the details there too. So we hope to see you in person in Chicago and also at the upcoming webinars.
I'd like to talk.
Go ahead, Mike.
Oh, I was going to go on. Go ahead with slide 4.
Perfect.
Mike LaPena, good afternoon or good morning, wherever you are. I'm going to talk about the different stages of contracting and some of the business issues that we face in contracting. Our firm and our group normally handles exhibits and background information and appendices to contracts, which are the guts of the agreement, but we don't, well, we respect what the attorneys do because these things have to be in an order that's going to be enforceable and dependable from a business perspective for both the vendor partners and for the employers, and important for the employees as well. There are a lot of different stages of contracting, and some of this starts with the very concept of a firm or a group determining that they want to get an on-site clinic, or they want to change a contract related to the on-site clinic. We think the first stage is to vet the vendor partner, we like to say, because they will be partners in this process, and make sure that what your goals and objectives and your desires are match what the vendor actually does, because with all the different vendors that we're going to talk about today, they all have different goals, objectives, frameworks, structures, legal ramifications for the contracts that they're developing, and capabilities. Generally, then there's a stage called a request for proposal. Some of these are extraordinarily complex. As a matter of fact, if you work with a large industry or a large national corporation, they may have standards for the RFPs or the request for proposal that are first have to be met even before you determine or define your scope of work. You're looking for a master services agreement to be developed at some stage. That master services agreement is going to have the statements of work, the pricing, what organizational construct there is, because remember, this is a paint company or a automaker providing healthcare for their employees. There's lots of implications that need to be separated in most states because of the private practice of medicine rules and the corporate practice of medicine rules. And these master services agreements generally define how that's going to work. The statements of work or scope of work or what's going to be done is, I think, the heart and the soul of a contract, because if this is not carefully rendered and crafted and detailed, then later on when people wake up to the fact that their goals are not being met, sometimes it's because their goals and their objectives were not articulated carefully. You'll find a very willing vendor partner who is operating under a different set of assumptions, and it's because the statement of work or the scope of work was weak. Renewals, every contract, one would assume and one would hope any relationship would be forever, but none of them are. You have to have a contract renewal phase, a contract renewal standard, and arrangements for adjudicating or reviewing or updating the contract renewal form. I say this more often now and point to it more often now because contracts have cycles, and these organizational contracts have not only hired physicians and providers, but they have articulation with healthcare plans, and they also have capital, and they're capital intensive. If we're going to build something, it means we've got brick and mortar. We had one contract where the party said, we want 5 years and 9 months, a 5-year, 9-month contract. This was the employer. And we asked, well, I had not seen that before, because we're trying to do things like depreciation schedules and stuff like that. They said 5 years, 9 months, that's it. Well, when I dove into it a little bit and asked them about it, they said, well, we have a contract to supply a certain amount of stuff for 5 years and 9 months. They were car parts, auto parts. And at the end of that contract, we don't think we're going to get a renewal because we know that the automaker is building their own stuff. So we're going to end the contract, lay off all the people, close the plant, throw the keys on the floor and walk out the door. But please don't tell anybody. But that gave us the idea that, okay, this has to be a contract that renews for a certain period of time, but has a termination at the end of 9 months in the 6th year of the agreement. Termination agreements are important, not because we anticipate termination, but because termination happens. We have several firms that require that contracts be rebid, not just the on-site vendor partner contracts, but all of their supplier contracts, their broker contracts, their insurance contracts, their healthcare contracts every 5 years. And that's just because of a compliance issue. And so we end up with termination provisions in every contract, which assign, and we'll talk more about this, who does what in a termination, even unlikely though it may be. And we certainly have seen vendor partners in the environment terminate contracts abruptly. And the protection for the employer has to be the terms in the termination agreement. So let's go on to the next slide and sort of separate legal from business terms here a second. I laid this out to process and pricing, and I would reference a couple of things that I think Stephanie will more clearly describe. Engagement of the team means get the whole team around the table to describe and discuss what's going to go on, because people entering the process at a later stage are going to be problematic to this. So your vendor partner is usually very well organized and they know exactly what their business case is. The employers, and we work mostly with employers, less so. Less so because we will be perhaps brought in by the board or will be brought in by the CFO. But we do need the HR people around the table. We need the OC health people who have contracts already in place. We may need the HR people. We're going to definitely need legal. So if we don't have the team around the table, we also would suggest that at that point in time, you can qualify some of your team members. We use this process in a Chicago-based operation at one point in time. We got the team around the table. We had the in-house attorneys, and then we began to start to talk about standards, and we turned to the attorneys to ask them how they would want to structure it. And this was a place that made it was a stamping place. They made forms for paint cans. Go figure. But they had a very robust operation. They said, we don't know anything. We can tell you how much noise we can make before we violate, city local standards here in Schaumburg or wherever we were. So many, because we're experts in that. That's what we get sued about all the time. And we can tell you about standards for employee hearing, because that's where we get disability issues all the time. So we had to go out to outside counsel. Well, the team has to be engaged from the start. You define the needs, you establish your program goals. If you're confused about these things, and begin to work with a provider vendor, if it's the right provider vendor, they'll help and they will partner right at these early levels. You have to sort that a little bit between sales, pep rally, and function, because the program goals should be core to the employer and to the employee base, and not necessarily just what the vendor or vendors you're working with might define. Best fit sources. This was all about vetting. We get a call maybe once a week. Somebody will say, we're going to try to do an on-site clinic. Can you suggest the best vendors? We always say, no, we can't. We don't know. We don't know who your best vendor is because we don't know what you're doing. And if they describe it a little bit, we could tell them, well, if you're in Louisiana and you're going to have a vendor that you want to have fit that environment or that type of a plan or program, here are 2 or 3 you might contact. But you have to if we can't even answer a question like that unless we first know what the goals of the program are, the scope, the size, the number of installations, all the rest of the stuff. We like to see an RFI and then an RFP. Request for information is less formal. The RFP is very formal. Request for information is, here's what we want to do. Do you guys do stuff like this? Are you interested? What's your timing? It doesn't have anything about pricing in it. It's just to try to qualify, do we even have people that want to involve themselves? We get involved with contracting for development of sites, and often we'll send out requests for information to many different architectural firms, for example, when we're building a set of clinics. And we'll get often very credible firms that excuse me, we'd love to work with, will come back and say, not now, not at this time. We're overbooked, or we can't work in that particular state. We don't have any licensed architects, or something like that. Narrow the candidates down. Seek out their form contracts. The lucky thing is that when we started first with these programs, there were no form contracts now, and we had to search for people who would help us understand what should be in them. But now the vendor partners all have pretty well developed and formal contract shells, and you should be able to get one so that you could see if there's something. It's not the contract itself, but you could see this type, style, and the format that they use to share with your own attorneys, so that when you do get into the contracting development for your own suitable program, then you're going to be able to move quickly. Then you work with counsel to modify and fit program goals. That's a process. Pricing, I mention this because everybody, the other question we get besides who should we work with is what should this cost and and we give them the consultative standard 3-word answer. That all depends. You should add modeling queries to the RFI. What type of pricing do you like to do? Not your price, but what type of pricing? And then sort the initial setup from the ongoing costs. The initial setup is often used to amortize costs that the vendor partner might otherwise have to put into your ongoing process. But if these initial setup fees include purchasing equipment that might be depreciated over a longer period of time, or software or whatever else, then Stephanie, well, I'm sure it will come up later. Who owns that stuff when they are part of a setup fee rather than an operating cost? That's a question we always ask. Capital outlay, whose balance sheet is it on? Some vendors have moved now to participating in the capital development of the sites, but that is not the traditional model. The traditional model is the employer provides the site, the vendor partner provides the horsepower to take care of the people and establish the program. You're going to have a cost plus, or you're going to have it per employee per month, or some other type of variant? Or are you going to have guarantees or risk sharing? Are you going to have performance adjustments along the way? And then always ask the question whether or not there will be basic modifications in some way we use the term value on investment, return on investment, value on investment. And if you're confused about those terms, as I am and I was, National Association of Worksite Health Centers has a very nice template for that. And one of the advantages to participating is you get access to an awful lot of information that is already done and already researched and already cataloged from mature programs. So there's a process. Pricing is separate from the process. It's unique enough that it deserves its own contract element. It's generally something which is the appendix or example to a contract. The next slide would take a look at the who the vendors are and why they might have different relationships with contracts. A health system, hospital, individual physicians, practice group, on-site clinic provider, partner, telehealth, and pharmacy. Very, very different organizations, and most programs that are very robust and mature will have multiple contracts. And if you chart the relationship, it may be, again, to that master services agreement, which was represented in the first slide, or in slide number 4, or it may be that the employer or its broker is going to hold some of these agreements in tandem with the on-site clinic provider. Let's take that first. The on-site clinic provider vendor is the most traditional and one that we think of most often when we're talking about on-site programming. And the on-site clinic providers are such that if you've seen one, you've seen one. It depends on the nature and its structure as to whether or not it is using sort of a cost plus approach, or whether it has matured in a different direction to accept risk or design other types of combination services. Um, One on-site clinic provider may develop dental and optical and wellness and include everything within its sphere of influence. Another may come as an agent and work as what we call a trusted advisor or a content advisor to healthcare and sit at the table and assist with the management of other contracts. So there's no right way, there's no wrong way. There's only not taking enough care to understand right up front where all of your services are going to be derived. I'd mentioned the health system hospital provider, newly emerging in the last 5 or 6 years, is a formidable entrant into most on-site clinic environments. But if you're working with Baptist, or you're working with Freudert, or you're working with somebody who's got or who prevails over a local area, the health system hospital provider may not have the breadth or reach to do multiple states, multiple sites. It may be localized. It may be very, very important local provider, but it won't be your 5-state provider unless it's a very unique type of organization. And I would say that my experience, Ascension has taken a look at this on a national basis, or almost a national basis. Tenet has, I believe, although I've not been involved with them on it. HCA has. We have been involved with them on it. So yes, some of these systems are looking at this and saying this is a important business line that we should be pursuing on behalf of our employers and on behalf of the patients in our communities. Individual physicians, that's a hireling arrangement, and somebody's got to hire that physician. If they're coming in as a provider, they should be through a physician practice group of some kind. When we work with hospitals, individual physicians, physician practice groups, specialty services, we have a whole different element of compliance introduced if we do not have a buffer like a broker, a healthcare plan, or an on-site clinic provider partner. Compliance is all about the Office of the Inspector General and HHS, and it's a very serious issue we'll talk about in a minute. Learned and experienced healthcare attorneys will keep you safe from it. Attorneys without healthcare experience will take you into the briar patch. That's all I can tell you.
Mike, can you comment about the corporate practice of medicine? About, can employers hire an individual doctor or medical group?
Well, the corporate practice of medicine in some 30 states, I believe, and in some states at a very, very brutal level, California, New York, Illinois. Stephanie will probably give you some more clarity on it. State that a business or a corporation or a non-physician cannot practice medicine and cannot be in a situation where they contract in such a way that they kind of sort of practice medicine through a corporate structure. And so what is developed generally is a private practice of medicine, sort of a captive or dedicated PC, professional corporation, or PLLC, professional limited liability corporation. And that is where the doctors and providers who have billing numbers being the numbers that providers have in order to be authorized to bill Medicare, Blue Cross Blue Shield, and other insurance and third-party organizations. So that stands separate. And then that corporation, the medical practice, a medical practice, contracts with an on-site clinic provider partner, and that on-site clinic provider partner owns the equipment, almost everything except the stethoscope. They manage the medical records. They do not own the medical records. They own the computer equipment. They contract and lease for the site. They hire all the non-providers. So the person that takes your information as you come through the door works for Ajax On-Site Clinic Provider Partnership, a Louisiana-based company. They provide the support processes for the New York-based PC, which is owned by Dr. Jackson. Dr. Jackson, our fictitious doctor, only holds his position and has given his stock or his rights to sell the stock up to another nominal physician that is controlled by the corporation. So I'm sorry for the long answer, Larry, but it's a very precise situation, especially tough to manage through in certain states, and something that firms, industries, and employers need to be aware of, because an on-site clinic provider partner, or maybe a hospital, or maybe a medical group, could make a mistake and get everybody in trouble.
Yeah, and Mike, that's a great explanation. So Larry, all 50 states have unique laws about the corporate practice of medicine. So anytime, especially where we see this as an issue, is when employers are managing their own clinics and hiring the provider directly. You will have to, like Mike said, set up a professional corporation that the physician owns in some states. In other states, and some, there's a few exceptions for physicians that are treating employees of a company if that physician is employed by the company. So again, it's a really state-specific issue. And the other thing we run into is, given the utilization of nurse practitioners and physician assistants by on-site clinic vendors, sometimes the corporate practice of medicine doctrine will not apply to other providers and only physicians. So it's something that you'll definitely want to look at state by state. And if you have operations in multiple states, it is kind of like weaving together a spider web to try to figure out the ownership and the agreements between all of them. So yeah, good question, Larry.
Yeah, it's an excellent point. It reminds us that being careful is one part of this whole process. I'll make a couple of other comments here. Telehealth providers and remote providers and urgent care centers are sort of in the healthcare community right now, kind of like, I don't know if people have, it's the 4th of July. If you've got pop-up fireworks places and you say, wow, I didn't know that they sold fireworks there. Well, they don't most of the year. We're going to see a lot of telehealth providers go out of business. So you need to be very careful about designing anything around a telehealth provider. And we're also going to see telehealth providers, on-site clinic providers, and specialty services providers changing their corporate ownership. So you have to be concerned about that, and concerned about the nature of a contract that you might sign as an employer being transitioned to another owner and to another set of management. That's a termination provision that you might want to have considered. So telehealth, on-site clinic provided, specialty services. So right now, if I wanted to have specialty services, I would think first of maybe orthopedics, obstetrics, gynecology. I already talked about optical and dental and stuff like that. We've got one clinic provider that's got, I think, 18 lanes of dental. When we opened up at one large firm, we had 6 dental lanes, and we had 10 dental assistants. We were 6 months out. We created a huge dissatisfaction factor for our employees, because we could not anticipate the demand for dental. Matter of fact, we absolutely were wrong. Not that we couldn't do it, we were just dead wrong. And so these specialty services all have their own norms and their own features. Most of the time, the specialty services have to be organized around some sort of hospital or some sort of physician group that has access to different types of organizational structures, different types of facilities, different types of imaging, et cetera. So just be aware of that. It may go through a vendor partner, it may go through a broker, it may go through your insurance program. So complex combination. Okay, so what are the key business and legal terms, legal issues and business terms? We have to separate these things out. And it's important to do that because different team members are going to have to work on different parts of this. And if you want to fast track this, everyone has to be working together sometimes and in parallel sometimes. Don't do all the business terms, then hand them to an attorney, because the attorney is going to correct you that and inform you that some of the business terms may be impractical or at least unenforceable. Back to Stephanie's comment that in some states, you can't even figure this stuff out because they've not done it before. So very important to have an attorney that's familiar with the healthcare parameters in that particular state.
Yeah, and Mike, I would add, just from a flow and process as an attorney more on the healthcare side, it's really helpful when I'm working with both vendors and employers to almost give me a list of those key business terms, and let's review that before we even get to the contracting, because a lot of them are perfectly fine, but for me to make sure that the language is drafted, let's say it's like a cost plus or per employee per month, to make sure I have the correct language, I need to understand the business terms. So from an efficiency standpoint, because with attorneys, I think one of the questions I always get is how much will this cost? How many hours is it going to take? If you can, like Mike just said, be really organized with those key business terms, it'll make kind of that process that much more efficient when you're working with counsel on trying to get the right language for the contract then.
I agree. So, so as I said, legal versus business. The legal issues are the form, the venue, where we're going to sue each other if we have to sue or communicate. Let's put softer terms in here. The termination process, whatever lease forms there might be, more complex these days because different people are owning the clinic brick and mortar. Any kind of indemnification clauses, extraordinarily important, often forgotten. Restrictive covenants of your employees as well as your physicians, a stumbling block when programs come apart or programs transition. A favorite doctor may find themselves with a restrictive covenant, unable to work for the clinic that's replacing the clinic. Assignment of the contract, I mentioned that already. What happens when your friendly local happy clinic provider gets purchased by a multi-state or national group of strangers who just kind of sort of have never been local at all? Articulation with other benefit contracts and programs, extremely important, especially with Health. And then formal communication processes established within the contracts, not assumed, never assumed. If it's not written, it's not part of the agreement. And if we look at the business issues that should be focused upon by the business team, of course, the price modeling, the services profile, what are they going to do? Articulation with the benefits. Wait a minute, that is on both sides. You're right, it's on both sides because it's a huge business issue if you don't have some sort of articulation with the benefits. And collaboration on program promotion, internal. We had one firm that had 270 contacts with each employee, 270, before their clinic opened. We had another who was concerned about the clinic opening and wanted it to sort of open in a stealth-like fashion. But one clinic was overwhelmed with demand. The other clinic was overwhelmed with patients ignoring it. So these things just don't happen by accident. Most vendor partnerships will include a marketing and communications plan. Definition of the scope of work needs to be detailed, not general. Clinic personnel oversight. Who's going to make the decisions about who does what, when, and where? And can I get rid of a doctor? Can I get rid of a person? Or can I ask that our favorite doctor be included within the clinic staff or within the clinic panel? The evaluation effectiveness, extremely important for the business people to be able to develop the program and make the claim to the CFO or to the board that this is what's going to occur. And then later on to be able to turn around to the vendor partner and say, wait a minute, I need those statistics to show that the money we spent and the continuation is buying something. And if you don't have the program evaluation and effectiveness channel wide open, there's going to be a problem. And then the span and control. Who controls what? What's the difference between governance and operations? So this was a big deal with COVID testing, when everyone had to spin on an axis 360 degrees and turn around from seeing employees who were on site to testing employees who were off site and getting COVID material and information out, and then move into the inoculation phase. So how quickly can the program, um, uh, I guess, bend to the needs of the employee population? So legal issues, business issues, they work in tandem, but different teams have to work on different parts of it. So my thought about the business considerations and the deal killers are many, but if you look at the different types of services and the different contract terms, primary care is show up, see people, and primarily access the primary care and satisfaction with primary care all happens here. Primary care also is asked to channel to specialty care. And so you never control the physician referral chain or network or structure, but you do have primary care involved, and you do judge their performance against how they utilize specialty care, imaging, pharmacy, and all the rest. The specialty care contracts are more specific. They may be by unit of care, or they may be by DRG, diagnostic related group, or they may be by event. We have all read about Walmart sending their hip replacements to Cleveland Clinic. Others in the New York area send their people to the hospital for special surgery, for orthopedics, and then they send their hearts and stuff like that to the Heart Center out on Long Island, CHSLI. But the specialty care is not only necessary for unique specialty events, it is for coverage in the emergency department and for access. Specialty, one of the most important specialty care contracts we think to look at is access to dermatology. We don't have enough dermatologists. Dermatologists don't care that we don't have enough. So how are you going to take care of rather routine rashes and skin diseases and problems when you can't get access to dermatology? So you have to look at your patient loading and your access and your throughput. Chronic disease management is all about care management. It splits down into 5 different categories. You all know the categories because it's all about, blood pressure, being overweight, congestive heart failure, all of the stuff that relates to turning around the cost of a health management program. So This is where the rubber hits the road on longer term care, and the care management component of these contracts gets into categories of patients. And to get into the categories of patients, you need to sort at the primary care level and assure the patients get appropriate direction, control, and management. OC Health, again, a state by state issue. It's different in Texas than it is in New York. And so if you work through OC Health, sometimes the on-site clinic program is not even going to address or touch OC Health. We've been working, and I think Larry's been working a long time to try to bring occupational health and workers' comp more in line with on-site clinic programming. But I will say that when we did the Toyota program is our best example or worst example. We did 25,000 square feet for the on-site clinic, but that we still had 8,000 square feet inside the plant with a separate staff for OC Health. And that's a Texas-based program. Very, very distinctive. Different records, different personnel, different reporting. Telemedicine and telehealth, again, I think it's all incorporated within primary care. The problem is that the telehealth and telemedicine and sometimes urgent care, that's off hours stuff. And it's easy to arrange using outside groups, but those outside groups have to articulate at all times with your medical record. Pharmacy on-site dispensing, again, a state by state type of analysis. Some states, pharmacy and on-site dispensing, easy to do. Some states, absolutely impossible. Wellness, I've often thought that wellness has no ROI or VOI. People criticize me for that. I say that, but I tell you right now that in our own firm, we have an on-site trainer, somebody who comes on site to lead our exercise programming. Individual people can leave and be on the clock to do the exercise training and the cardiopulmonary training. We have an entire mini gymnasium for that. So I totally believe in wellness services. Wellness services, however, are very much individual to a locale or area. We have no reference for licensing, for efficiency of dollars spent on the wellness services. I just don't believe it exists, having tried to contract for those things many times. So make it available, make it robust, but channeling people to it. My worst example is we had guys who and some ladies who were playing basketball every day at noon at the Y. And so they're playing 3-on-3, and they were very, very healthy people, and they would go down there. And so we said, we should have a gymnasium. And so we're sitting around a table, and I always agree, sure, let's build a gymnasium. And then after we built the gymnasium, we evaluated it a year later. And guess what? The people who used to play at the Y played at the gymnasium that we just built, but nobody else did. So we had a beautiful program, but we had missed the boat on it. Facilities do not create wellness. Program guidance from primary care probably has more to do with it. EAP programs, very highly regulated on a state-by-state basis, really well or appropriately tied up with HIPAA, which Stephanie will cover later. This is an area where you should tread with real care because it has a great deal of implication for liability, for information being leaked related to people who have severe dependency programs and addiction and stuff like that. I cover the fitness center. I'm in favor because we've got one. But the place that if we went into a business approach on this, the place that's going to make you money is going to be your rehab center. And the rehab center can be really well coordinated with the fitness center. Rehabbing on site and rehabbing in coordination with the primary care makes a lot of sense. A fitness center is more a public relations program, I think, for the employees than it is a healthcare adjunct. And it is generally not something that you would find associated with on-site clinic vendor partners, but I stand to be corrected on that. Smoking cessation. The firms that I work with, no smoking any place on the campus. And if you're, and in many cases, the smoking cessation is tied to a reduction in fees and costs. Key business considerations, last thing to talk about, cost of services, the payment terms, billing and pay requirements, location of service. The billing and pay requirements I want to focus on a little bit, because when you're charging for stuff or giving it away for free, there are legal implications. The billing and pay requirements in some cases are a great way to keep track of things. If you have a copay or deductible, it's a wonderful thing to generate a medical record or a medical registration. And NAWHC is also working right now on important legislative things to assure that the tax treatment of the on-site clinic programs aren't confused with different types of benefits that would cost employers money. So location of services, where do you have them? Types of medical providers utilized. Are you going to use NPs or PAs? That's something you should get defined up front, because NPs and PAs, in some cases, some states are not well utilized and not well recognized, but in other states, they are absolutely the providers of choice. Performance and guarantees. I will say something about guarantees. A guarantee of the most important guarantee that we think exists that can be quantified is, when does our program start? When does our doctor get here? And that is a great qualifier for a vendor. If they can't tell you who the doctor is going to be and when the program is going to start, or if they are not able to provide or to perform on that level, that's where a guarantee really means something. It's one of the great dissatisfiers of employers to have a program slated to start July 1st, but it just can't start until, some months later, because they had the foresight to build the building, but not to track and recruit and seal in a provider. Utilization tracking, of course, health data analytics. Health data analytics are mostly contained within the EMR program right now, and ownership of those data analytics are extremely important, as Stephanie is going to talk to you about. The risk assumption and assignment, vendors will come in and say, we take risk. And so we'll say, you do? Wow, that's terrific. So what kind of risk do you take? Well, if we don't get it started on time, then we'll forego half of our setup fee. I said, well, that's not risk, that's a money back guarantee. I get a money back guarantee when I order something from TV and I get it and I'm not happy. As long as I pay the shipping, as long as I pay the shipping to send it back, that's a money back guarantee. Risk means I am invested in $25 per member per day, per member per month, per member per event, and you're going to make it happen for 20. So the risk assumptions and assignment, risk is really risk. It's HMO style risk. It's across a population. And it's the statement that many vendors make, saying to the parties that we're going to actually reduce or bend the healthcare cost curve. So other business considerations, who are you going to cover? Employees and dependents, right? Infant up through. Are you going to cover people on site but contracted. More and more employers are using contracted labor. Well, what happens when these people come on? Are they going to be able to, even though they're employees, they wear a shirt just like everybody else with an employer's logo on it, but do they get to use the on-site programming? Marketing, how do you market? Go ahead,
I'm going to jump in on that. Two things I'm noticing a lot of is people wanting retirees to be able to continue utilizing the clinic. We're seeing that more and more, especially when you've had a long-standing physician there. And that gets into a lot of really complex issues if the retirees transfer to Medicare. So it's definitely a flag if you ever want to use or allow retirees to use. And then COBRA considerations too. If one of your employees quits, under COBRA, are you going to allow them back on site to utilize the clinic, which gets on to, security issues, both from an on-premise, just workforce standpoint and privacy standpoint. So two other kind of little unique things we've seen covered in contracts lately too.
Right. The COBRA thing is a real conundrum. The Medicare thing is articulation with Medicare is a big problem. And in a lot of cases, the employers are just shrugging their shoulders and saying, if you're on Medicare and you're retired, have a good life.
Yeah.
And remember that has a lot to do with how the clinic is accredited. The clinic may not have Medicare provider numbers. So we could get to that in a minute. Some employers, I'm sure Stephanie has worked with, have solved that problem, but they don't solve it easily.
It's expensive and challenging. So yeah. It can be done, but it's hard.
Challenging, but not impossible with the right lawyer.
Thanks.
Hours and days of operations, that's simple, but the hours and days of operation, you have to have flexible, because if the plant goes 24/7, or if the plant modifies hours, you've got to have an immediate modification of the days in operation schedule. Who gets to choose the subcontractors? Maybe you already have a telehealth program, already have a pharmacy or PBM or pharmacy benefit manager. Ownership of equipment, pharmaceuticals, et cetera. The pharmaceuticals are easy. That's going to be defined by state law. But if I bought an imaging unit and installed it as an employer, I guess I own it. If, however, Ajax vendor partner bought it and it's installed and lag bolted into my wall and they leave, who owns that equipment? Because I kind of sort of paid for it as an employer. That's the type of argument you get into. And they can't take it and they won't want you to have it, or may not be able to give it to you because they've got a lease and a master lease on a bunch of them. So that's something that you want to define right up front.
Yeah, Mike, you made it real quick on the pharmaceuticals, and I'll talk about this a little more, but the state law is really going to drive that. So most employers, the HR manager cannot own the pharmaceuticals. The physician needs to own the pharmaceuticals, or the on-site clinic vendor, the pharmacy, right. And that can get into some tough issues we'll talk about later when you're transitioning vendors. And then on the equipment side, we've also seen some issues come up in larger clinics that have pretty sophisticated medical devices on site at the clinic. And so not only who owns it, but from the vendor's perspective, do you want to leave that on site at termination? Because are you worried about liability if that's used incorrectly? Or do you want to take over another vendor's equipment and medical devices? And again, from a liability perspective, so a lot to think about there. And, it's all about, I think, structuring it, like Mike said, at the onset correctly and thinking through these things when you first get with them, because when it's time to divorce and break up, it'll be a lot easier if we've gone through all this at the beginning than trying to figure it out at the end.
Right. The pharmaceuticals, we're going to wait and ask Stephanie later how she gets the rebates from the PBM back to the employer. And then she could probably help us with 403B plans that, pharmaceuticals are a mystery, and it's a regulated environment, but it's not understood by anybody. Regulatory compliance, we'll talk about that in a more complete fashion in another slide. The term of the contract, termination rights of the parties, very, very complex and very detailed. And nobody likes to talk about the termination rights of the parties and transition upon termination. But and we are talking about having sort of like a prenuptial agreement, because we know, unless, I mean, like marriage, until death do us part, that sort of stuff, we know that these contracts are going to have an end. And these contracts have to have an end, but the corporation may go on or may go forward. So you have to define and really work carefully on the termination rights of the parties and the transition. So last slide, standards versus compliance. And I want to highlight this because we talked about a bunch of the standards in the contract: performance and patient employee satisfaction, health status, articulation. Okay, what else? All right, so on the standard side, I think it's very well understood. Compliance, you have to think about this as a legal term that defines how healthcare organizations relate to each other, especially as Stark laws, fraud and abuse, anti-kickback statutes, and stuff like that might affect them. But more than that, healthcare providers are licensed, and there's a certification of providers. Clinics are certified NAWHC, JCAHO, and other certifications. You've got HIPAA regulations, OIG, and state compliance matters. This is not to say that all these things are confusing. It's just to say that if you paid for licensure and you paid for certification of your organizational construct, then consider these things when you talk about termination. And so we certification of clinic, for example, has policies, protocols, very definitive organizational standards, governance minutes. And if there's termination and the vendor walks away and takes that stuff, then a lot of work has gone into it on the employer's side, and they've lost something. But if the vendor walks away and then there are needs for access to records, for example, OC Health or something related to OSHA regulations or credentialing or some sort of reporting process that should have been done for which the vendor partner was responsible, they're going to have to go back and work with the employer. Right now, our firm is working with two different events where we're going back to 2012 to try to reconstruct things to explain to federal prosecutors what happened. We weren't involved in any of this stuff. We have to be hired as outside consultants to trace through a bunch of stuff to come up with an answer. I don't think anybody did anything wrong, but nobody can prove that no one did anything wrong. And this is the compliance conundrum. You have all of these organizational standards and all of the minutes and all of the performance objectives and everything else that have been committed to over the years. And then later on, if someone wants to go back and there's been a transition without coordination, a transition without an agreement for mutual support, then you're in a mess. So compliance. Generally with a hospital, there's a compliance officer. That person should be at the table. I think most of the vendor partners who are mature organizations have a compliance officer. And I think that compliance officer needs to sign off on a lot of this stuff. So in any case, key legal considerations. I'm hoping that Stephanie will clear up some of the things that I've said, which may have muddied the waters. Thank you very much.
Thanks, Mike. So before I really jump in here, I mean, I think, one of the things I noted throughout Mike's presentation was the business terms really cross over to the legal terms. So for example, integration with benefit plans. He talked about termination. And so all those things that you're thinking about from a business side have legal implications too. So one thing, I mean, I won't go through all of the things in detail here, but I think, hopefully this presentation can also be used almost as a checklist. So when you're contracting, especially if you are a new worksite health clinic, look at some of these slides and think, is there indemnification? Are there any limitations of liability? What are the insurance provisions, right? And if there's things missing in the contract that are covered here, that may be okay, but it may be something you want to ask, well, why do I not see anything in the contract about insurance? So in addition to some of the things Mike talked about, I wanted to go through a few others. So, you really need to have benefits counsel involved at all times. If you have an high deductible health plan, an HSA, you need to think about the COBRA implications and ERISA. And most of that is really the responsibility of the employer and not the vendor to ensure that the benefits plans are coordinated with the on-site health clinic. But because of the way the benefits plan is structured, you may need to make sure that your vendor is charging a copay or billing things correctly. So there really needs to be a lot of communication. I won't spend any time really on indemnification and limitations of liability, other than you do see it in contracts. So again, really review it carefully. I feel like people get through all the business terms and the detailed statement of work, and there's almost fatigue the time you come to these legal provisions, but they're really important from a liability perspective. I'm going to talk about insurance, IP ownership, and cybersecurity here in a second. We're going to talk more today about ownership and retention of medical records, the restrictive covenants, and then I will just say assignability. Mike really hit on that. A lot of contracts can be assigned, and I think from the employer side, you need to think about, okay, if I contracted for one provider who's a small local provider and they're purchased by another large provider, do I still want to keep using them? But I think the vendors need to think about that too. If the company that they're providing services for, the auto manufacturing company, merges with another company, what happens to that contract? What if the other company already has a vendor? Who has the right to terminate? So it's really something that both parties need to be thinking about. Again, just a few other things to put on your checklist when you're negotiating a contract. So let's talk about the medical providers. I'm not going to name all of them here, but one thing to really think about, and this really becomes, I think, an issue in a lot of contracts I've seen where we have a bit of a dispute or there was never a meeting of the minds, is what medical providers are going to be used and what are the cost of those providers. So of course, you're going to be spending less money on a nurse practitioner or a physician assistant, but at the same time, once you get into that contract, from a scope of practice perspective, would you prefer the physician? Same with the registered nurse versus the licensed practical nurse versus the medical assistant. Who do you prefer there? And what's the cost and what is their scope? So those should all be things you're sitting down and working with the vendor on. And really, if the vendor is sophisticated and they've been in this area, they're going to have a really good understanding, I think, of who's going to be the right fit for your clinic based on the scope of services and the needs. So with the medical providers, when you're working with, especially an on-site clinic vendor or a hospital or health system, you're going to make sure that they have certain credentialing requirements. This usually will not be on the employer unless the employer is managing their own clinic. So licensure, board certification, are they running OIG exclusion checks, which is a best practice, even if you're not dealing with Medicare, which you likely will not be. Do the medical providers have regular office hours? This has been a big issue I've seen in, when we're trying to work through issues between the employer and vendor, is the clinic will be open from 9 to 5, but when is the medical provider actually on site? And do you have to schedule appointments? Do you have to walk in, or can you walk in? And are the medical providers on call? So when you have that 24/7 factory, can you get a hold of those medical providers? And again, things that I'd rather see the parties work out in advance than try to, wade through, 6 months into the contract. This is a big one. Do you get to assist in choosing the provider? So as an employer, do you get to interview the provider? Do you get to help choose who that medical doctor is? And with the vendor hat on, do you want the employer choosing the provider, right? Because you're going to have your own vetting that you do of providers and credentialing requirements. A lot of times I will see the employer get an opportunity to meet the provider, and make sure they're a good fit, but they don't get to choose the provider. Again, because the vendor does need to make sure that there are certain standards and qualifications met. Do you get to interview the staff? That's something I've seen come up more and more lately in these new contract negotiations and RFPs. And you have the right to terminate a staff member. So this has been a really significant issue where you may have a physician or nurse practitioner or MA that is just not a good fit. And so if you have your employer hat on, you need to think about, what does that look like with the vendor? Do I have any control over who staffs the clinic? And if, you know, I have a provider that really does not get along with our employee population, will the vendor work to get a new provider in? And do they even have the option? You know, especially in some more rural areas we see where there's just a huge shortage of providers too. So navigating through those staffing issues is really, really critical. And can the staff stay if the clinic provider transitions to a new provider? So if you have on-site clinic vendors that switch, you know, it's just something to have a discussion up front with your on-site health clinic provider, so you know what to expect. You know, if that provider leaves, then the actual medical providers, the physicians and nurse practitioners, go with them, or they can stay, but it's a discussion you need to have. And one thing I saw is the on-site clinic provider that was leaving was going to allow some of the staff to stay, but the new provider didn't want to use that staff. They already had staff lined up. So it's just a really open and transparent discussion you need to have, you know, when you're going into that contract discussion. And then, do you have any control over the referral network? Mike talked a lot about that, so I'm not going to talk too much, other than, again, with the corporate practice of medicine, you know, even if it is not prohibited in the state where the clinic is located, the medical provider needs to use their independent medical judgment. And it's very critical that you allow them to do that, whether you are the vendor or the employer. And that sometimes is also going to be as it relates to referrals. So not only, you know, do we not want to control the independent medical judgment of the provider and the treatment decisions, but also in making the best referral decision. So it's a fine line between having your specialty services contracted, but making sure that that provider can get the patient the specialty care they need. So another thing I wanted to dig into in a little more detail today was the utilization tracking and health data analytics. So does your contract require the provider to track and share participation and utilization metrics? Again, this is another discussion you need to have with your vendor about how, you know, do they do this, if at all. And it's a really nice tool to compare, for example, your non-clinic utilizers to your clinic utilizers to determine ROI. If you are going to have the vendor sharing utilization metrics and other information, let's say with your broker or a third-party administrator, from a legal perspective, you're going to want to make sure you have the right agreements in place, such as a business associate agreement or a data processing or data sharing agreement or addendum. I won't spend too much time on this, pretty basic, but insurance requirements, definitely something to think about. Most contracts, all contracts really, should lay out the types of insurance that the vendor carries, but also the types of insurance that you may want the employer to carry. So for example, if the employer owns the space that the clinic is located on, it's an on-site, not a near-site clinic, let's say, and there's a slip and fall, does that employer have the adequate insurance to cover that injury, or is it a workers' comp claim? You know, thinking through that. So just the types of insurance, and I would say not all insurance is equal. So think about not only what types of insurance, but what are the occurrence versus the aggregate limits. So for example, your cybersecurity insurance. I dealt with a situation recently where, and I would say this was not in the on-site clinic space. It was a different type of healthcare provider, but they had a $25,000 limit for cybersecurity insurance. So when they had a significant data breach, that $25,000 was gone very quickly. Who's naming whom as an additional insured, and is someone's insurance policy primary versus secondary? And from dealing with a ton of contracts, one thing I really advise both employers and vendors to do is get their risk management or insurance person to actually review the technical insurance language, because they may see something in there that, you know, the business person or the attorney may miss or may say, man, we can't do that. So I saw one recently where the employer asked the vendor to allow the employer to choose counsel, and put that into the insurance policy, that the employer could choose counsel should there be a claim. And we went back to the broker and the carrier, and with the way the policy was drafted, that just was not possible. And so had we agreed to that, it's something right away we would have not been able to comply with. So again, just thinking about these different things is really critical. Let's see here. Okay, intellectual property. And what I mean by that is not medical records. We'll talk about that in a second. But it's the intellectual property associated both with the vendor. So, they're going to have their trademarks and their trade names, but also with the clinic. And so I think what you need to think about, and the reason this gets into contracting is, if you're using an on-site clinic vendor, is the clinic going to be called, the name of that vendor, the Health Associates Clinic? Or will it be the name of the employer or something totally different? Maybe you want to come up with some different snazzy name, and who owns that? And so pretty standard. We don't really see a lot of disputes over this. But I think as far as like marketing materials go, if you have a website that is separate for the clinic, those type of things, you're going to want to think about who owns that. And that's especially critical when you transition on-site clinic vendors. So is that a name and marketing materials that stay with you and you can keep utilizing, or does all that go with the vendor? So, who created it, who owns it, is it work made for hire, all of those things. Okay, employee health records. We could spend a very, very long time on this, and we have another webinar coming up in October on this, so I won't spend too much time. But before we even talked about the contracting issues, I wanted to put together a slide that went through all of the different laws. And this isn't all of them, but it's a lot of them. So I think anytime, especially if you're getting ready to operate a new on-site clinic, but even with current ones, you need to sit down and think about, what records do you have, what laws govern those records, and who owns those records, and who's responsible for retaining those records. And you almost have to create a framework with all this. So for example, I'll touch on SAMHSA. That would be your EAP records or SUD records. So your employee assistance program, if you were doing substance use disorder treatment within that program and it qualifies as a program under 42 CFR Part 2, you are now subject to very, very stringent records, much more strict than HIPAA, that carry criminal penalties for the disclosure of those substance use disorder records. And you do see EAP programs that fall under 42 CFR Part 2 and are governed by SAMHSA, in addition to HIPAA. And so that's why you really have to make that trade up and think about, before you even negotiate this contract, what laws govern the records. Because that's going to get into ownership and retention of the records. So one, who owns the records? If you have a on-site clinic, provider, you have a physician there, do they own the records? Do the patients? Do the employer? And that is going to be governed by state law and federal law. And so that's going to be a really critical thing to think about and to talk through with your clinic provider from the beginning, and figure out who is responsible for compliance with those laws. So going back just quickly here, I highlighted the new Cures Act and information blocking rules. That is a new law that applies to all healthcare providers. Unlike HIPAA, which only applies to covered entities, which are healthcare providers that conduct standard transactions like billing, the information blocking rules are not just applicable to covered entities. They're applicable to all healthcare providers. And so one question we're getting a lot of is, does that wrap up the occupational health providers too, right? Who really have not been as concerned about HIPAA. And so when we go back to all these different issues, understanding the compliance framework is going to be really critical, both on the vendor and employer side. Another thing that we see a lot of is who gets to pick the EMR or the EHR and who contracts with the EHR vendor. We see a lot of on-site clinic vendors use your more traditional vendors like an Epic, but we also see a lot of occupational health vendors or occupational health EMRs that really specialize in that. And so it's really critical to think about who's going to have that EMR and EHR contract and what is the access going to be. Integration with multiple platforms. So what I mean by that is if you're doing primary care at the clinic, but you have a separate telehealth provider, does the telehealth provider integrate with your main EMR system that the on-site clinic vendor utilizes? And if they don't integrate, how are we getting records from one system to another? Are we scanning them in? Are we just copying and pasting? And that's really important. And it's something Mike said earlier, and I'm glad he brought up, because when you're going back and looking at records from 5 or 7 years ago and there's an issue or dispute, we want to be able to go to one database and see one set of records, or at least have notes in there stating also see the telehealth record, right? So we really need to understand that integration. Again, termination and transition of the clinic, this is really critical. So when the provider leaves, what happens to those records? Who has to maintain those records? Most healthcare providers under state law have an obligation to maintain records for a certain number of years. So for example, in Indiana, it's 7 years. However, do we have a situation where we are going to transfer those records, or at least copies of those records, to the new clinic provider so that they have those and there's complete continuity of care? And if we're doing that, we need to think about, can we transfer those records under HIPAA, under the treatment exception too? I've also been in a situation where we had a termination of the clinic provider because the employer decided they just wanted to shut down the clinic. Having an on-site clinic was no longer the right move for them. So that was interesting because then we didn't have a transition of records. We had to send patient notices to the patients about where they could obtain copies of their records after the clinic went away and who was responsible for maintaining those. And in that case, because it was primary care and not occupational health, the provider did keep those records. Employer and patient access, especially if you're a new clinic, I think it's important to understand who from your management or HR team can have access to those records, and it's pretty much no one, except if you were doing some occupational health, return to work, that sort of thing, workers' compensation. You know, sometimes there could be exceptions there, but I think it's really important that employers and vendors have a meeting of the minds as to who can have records, because I've also seen situations where you've got the HR manager or the administrative assistant going down and knocking on the door of the clinic, wanting to know who was in there and why, right? And we're having to educate them about different state and federal privacy laws. And it happens every year. I swear we have someone that wants to find out, you know, why was, you know, the person in the office next to me in that clinic for 2 hours, what's going on? So just really education on that is important. I put patient access here. If you are on the vendor side, you are going to see lately a slew of enforcement actions from HHS, Office for Civil Rights, for healthcare providers not providing proper access to patients under HIPAA. And now with the new information blocking rules, that's going to be a bigger issue too. And so, for example, does your vendor use an EHR system with a patient portal? You know, how is that handled and who's responsible for that? Then probably one of the biggest issues I see in this area is the retention requirements. So OSHA has very long requirements, you know, 30 years. So who's responsible for that, and is that laid out in the contract? I am actually going to show a different document here quickly. So I will talk about this more when we get into details on records, but really vetting your vendors is critical. And if you're running your own clinic, or you know, you have a telehealth provider the employer is working directly with, making sure that you understand their security and compliance background is critical. And one thing we've done, actually, oh, there we go. Okay, so this is a vendor questionnaire that I've put together. If anyone wants a copy, I'd be happy to share it with them if you want to email me. But really just going through here and finding out about that vendor. You know, do they perform annual security audits? Do they have HIPAA privacy and security policies? Do they use a public cloud vendor, or do they use an offsite facility? Is any data stored outside of the US? That's going to be a really big deal if they're storing data now outside of the US under GDPR and the Schrems decisions. Or if you're an employer and you have employees outside the US, also significant. So really just understanding how to vet your vendors. If you do it right from the beginning, it's going to save you a lot of heartache. Mobile device and social media policy, that's a big issue we've seen both for employers and vendors lately is, you know, what are they allowing to be used and posted on Facebook or LinkedIn and Twitter too. I'm running out of time, so I'm going to go quickly here. So contract considerations. And I feel like right now we're talking so much about things that impact even the operations of the clinic, but the reason we're doing it is all this should really be in your contract. So when you're getting ready to contract with that vendor, thinking about, are you going to have an on-site pharmacy, which I know a lot of the clinic vendors do, or are you going to have on-site dispensing, which a lot of the clinic vendors also do. And I think there's a lot of advantages and disadvantages on either side. So I'm not here to talk about the business points of that today, but you know, if you are going to have that on-site dispensing, is it required in the contract that the vendor provides that capability? And what is the formulary? Who decides the formulary? Is it the vendor provider, or do they do that in conjunction with the TPA, the third-party administrator, and the broker, and you know, people like Mike who help on the employer side? What's the cost of medication and the medication rebates and transparency? And that's been a big thing lately from a contractual standpoint. We've been looking at is, you know, how do you know how the rebates are calculated? Are those passed through? What's the transparency there? And so really thinking through that if you're on the employer side with your vendor, but if you're on the vendor side, thinking about that too with whoever the pharmaceutical company is that you're utilizing. I'll really encourage you guys to do that. Who owns the medication? So we talked about this just a little bit. Really, the employer should typically never be in a position where they own the medication. That should be owned by the provider or the on-site clinic manager. And one thing that can be tricky with that is if the clinic is terminated or you transition to a new vendor, the employer may have already paid for that medication, but they still typically should not keep that medication after the vendor leaves. And if you're transferring medication between vendors, there's wholesale distributor drug laws we need to be thinking about here. So again, it's like at the marriage, it's always great. The honeymoon phase, it's when we break up that everything falls apart. So, you know, work these things out in advance while everyone really likes each other. Does the contract require data analytics on medication adherence and utilization? And we talked about that one a little bit. So I'm going to end here with hopefully just about 5 minutes for questions, and I'll go through this pretty quickly. So when you think about ending this relationship, one, what right does the employer have to terminate the contract without cause? And does the vendor have to terminate it without cause? And how much notice must be provided? Typically 30 days notice is not enough. You need 90, 180 days. And we talked about some of this other thing that we're, you know, items we're going to be thinking about, like transitioning staff and pharmaceuticals. I would require upon contract termination that you get certificates of insurance if you don't already have those, in case there's a claim brought later. And then lastly, the patients. We're doing this because of the patients. And so when there is a termination or transition of providers, really thinking about who's notifying the patients, and there's usually a state law requirement to do that on the provider side, and continuity of care issues, medical records, and the ability of that patient to continue seeing the provider, even if the provider goes into private practice in the community. So these are all things we should be thinking about. Okay, well, I know that was a lot for an hour and a half. So do we have any questions?
So that was great, Mike and Stephanie, very much appreciate that. Yeah, let me just go through the people who are on the call to see if you have any questions and comments. So let me start with Alex Jordan. Any comments or questions you have?
So comment, great job, very comprehensive, and appreciate the feedback. One question, are there recommended key contractual terms that should adjust or modify over time as a new clinic then becomes a more mature clinic?
I have seen that actually, both on the business and the legal side. And so like on the legal side, I've seen it, for example, with termination rights. Maybe in the first year, there is no termination without cause that the employer can provide, because the clinic provider and employer, frankly, are investing a lot in that. I've also seen it on the business side where we have done kind of scaled pricing for a per employee per month that changes over time, and same with the guarantees on that. I've also seen it where there's more flexibility for the vendor to control the providers, the formulary, and things like that after the clinic has been open for so long, and there's kind of that relationship of trust. So I do see that a lot, where you'll have that initial term of maybe 2 years, and then different terms or terms that are to be mutually agreed upon renewal. But Mike, any thoughts on that?
Yeah, absolutely. And we see it with scale and planning on-site from startup to maturity, where we change prices maybe 2 or 3 times during that phase. So very much a flexibility example in the early stages of the contract.
Thank you.
Great, thank you.
Amy Marshall, any comments or questions?
No, I don't think so. This was great.
Thank you. Bridget, any comments or questions? Bridget? No? Okay, Kelly Tauber. Kelly, any comments or questions?
Good afternoon. So I guess my only question is do you ever run into any kind of conflict of interest issues if the providers are doing both primary care and occupational health exams for the employer population?
Yeah, so I would say yes, but it can be managed. When I first started kind of working in this industry on the legal side, I would say I never saw providers doing both. And I think it's becoming more common now, but I think you have to have a very sophisticated provider, frankly, because you have to have safeguards and guardrails up, right, in order to be able to do both. So for example, access to data is a really big one. On the occ health side, the employer would have access to certain data, but of course on the primary care side, they do not. And so being able to separate those out is really critical. And I think the other thing that's really hard about that is just the patient trust. I work with some clients who, both on the vendor and employer side, who do both the occupational health and the primary care. And it's just a huge level of trust you have to earn with that employee that's coming in to talk about their depression, but then also coming in to talk about their hurt wrist, that's the occ health injury. So I think it can be done, but you've got to have a lot of policies and operational safeguards in place to do it. Mike, are you seeing that much?
We always try to do it, but we've succeeded maybe 1 time out of 5. It takes a medical director for occ health who's extremely strong and who is trusted by the employees, and of course the separation of records and absolute adherence to state law so that you don't get into trouble. It makes all the sense in the world, but it's very, very difficult to achieve.
That's very helpful. Thank you very much.
Great. Thank you again, everyone who participated. Thank you, Stephanie and Mike, for taking the time out of your schedules to support us. We look forward to seeing everyone hopefully at our next program, which will be in July, talking about payment structures. And after that, the annual conference on September 9th and 10th in Chicago. So with that, everyone have a good holiday weekend. Be safe and healthy, and look forward to seeing you in the future.